The topic of today's lecture is breast imaging. I'm your educator, Dr. Ali Imran, and let's get on with it. So, the primary thing that we do in breast imaging is mammography. Now, mammography is used both as a screening tool and as a diagnostic tool. Now, usually patients are referred to the breast imaging via physical examination, but physical examination of the breast is not good. Why? Because it has both low sensitivity and low specificity. Now, because of low specificity, it tends to have overdiagnosis, and because we know that more than 85% of breast tumors are benign, this results in less patient care. And also because the physical exams have low sensitivity, it also tends to have underdiagnosis of the patient, which again some patients do not get diagnosed with malignant tumors when they have one. So breast imaging is the absolute tool in order to both diagnose and screen for breast cancers, even though physical exams are usually performed. So, as a screening tool, the mammography is done like this. This is an image of a woman getting a mammogram. So, this is the device which is used, and it is used on each breast. First the right one, then the left one. Now there are various views through which it is done. It can be done via various views, but we will discuss those projections later on. Now mammograms only have one drawback. The only drawback they have is that they usually get false negative results. Now, what is a false negative result is that sometimes masses which are not present, sometimes adipose tissues accumulate together and they form a mass which may look like a palpable mass, but it is not. It's just a collection of adipose tissue. So the frequency of false negatives is high in mammography than in physical exams. But still, mammography is superior to physical examination. Now, as I said, that it is used both as a screening and diagnostic tool. So first, we're going to learn how it is used as a screening tool. As a screening tool, every woman around the age of 30 to 40 who is on the average risk of breast cancer must have mammogram every year. Now, mammogram is easy, it's quick, and it uses very low dose of X-rays. So the risk of ionizing radiations is very, very low. One study even claims that even if someone gets yearly mammograms, the chances of getting fatal radiation exposure is 1 in 80,000 years. That's how much low radiation a screening mammogram uses. So it's a myth that yearly mammograms causes cancer. No, it is a tool to diagnose, to screen, to find out cancers, to find out tumors. Next, we will talk about different projections. Now, as I said that both as a screening tool and as the diagnostic tool, mammograms have projections. Just like chest rays had projections like the AP view and the PA view, it has its own projection. The first projection is called the craniocaudal view, where the X-ray source is superior to the breast and the detector is inferior to the breast. This way, the breast is both are screened throughout, and whole of the breast is projected on the detector. Now, the other view that is also used, the other projection, is called the mediolateral oblique view. Now, this is a very special view that is only used in mammography. And this is the view that was being done in the last picture. As you can see, both the detector and the source of the X-ray are in oblique view. Now this results in the MLO projection or the mediolateral oblique projection, in which the X-ray has a superior lateral, the X-ray source has a superior lateral angle, and the detector has a mediolateral angle, and it is done in an oblique view. Now, why this projection is done along with the craniocaudal view, which gives us the view of the whole breast, because this view also includes the pectoralis muscle, the pec major muscle, and it also includes the axillary area or the axillary projection of both the breasts. So if you want to examine the axillary area and the axillary projection of the breasts, the MLO view is ideal. And if you want to view the main parenchyma of the breast, the CC or the craniocaudal view is more ideal. Next, we'll learn about the densities of the breast. Now, when a standard screening mammogram is done, the breast has two kinds of densities. The first one is the fatty one, and the other is the fibronodular one. A normal breast, like in this picture here, has scattered fibronodular densities. It has both the fat and the fibronodular densities, which are scattered. But this is not the only normal picture you see. Sometimes, instead of having uniformity, this scattered fibrograndular density is heterogeneous. Now, heterogeneous means that it is not regular. It has an irregular view, like in view here, that it is clumped together here, it is absent here. So this is also normal. And sometimes, especially in smaller sizes, you find that breasts have extremely dense fibronodular tissue. Now, this extremely dense fibronodular tissue again is normal. This does not indicate a mass, and this does not indicate anything. It's a normal projection and it's part of the normal view. Now we learn about what we look for when you perform a screening mammogram. Now there are two kind of things usually we find. We find calcifications among the fibronodular tissue, and we find certain densities. Now these densities can be developing. They can be absent in the previous mammogram and they slowly appear in the preceding mammograms. That's why it is absolutely necessary to view mammograms in conjunction with the previous ones, because new densities are light and they're not easily found. So a comparison with the previous one should always be done. Here is an example that this asymmetrical density which is being developed, as you can see that it is very light, is absent in the previous one. Though calcification, this area, is present in both, but the developing density, which may be benign, may be malignant, we do not know at this point, is developing and was absent in the previous one. So a screening mammogram is also a detection tool. So when we see this density which is being developed, we advise further investigations, further MRI, CT scan, biopsies, whatever is necessary to further diagnose what is happening and what kind of density it is. Next, we'll learn about the architectural distortions. Now, sometimes tumors do not cause a density to appear in a mammogram. Now, what they do is that they perform an architectural distortion. An architectural distortion can be defined as the structure, the whole structure of the breast, along with the skin, is disrupted, and this results in the dimpling of the breast tissue in the physical exam, especially those architectural distortions which have a focus and have stellate appearance with spikes protruding out. This kind of projection, this kind of distortion is especially suspicious of having a malignant nature. So, not only developing densities are noted along with calcifications, but also the structural distortions. Now, next we'll learn about breast calcification. As mentioned earlier, not only we find densities and architectural distortions, we also find calcifications in the breast tissue, and calcifications are normal. They are so normal that they are usually found in the normal breast tissue. Now, calcifications in the breast tissue are usually of two types. They can be malignant, though they are usually benign. One can find out in the screening mammogram by having a look at its center. If the center is radiolucent, that it does not correspond with the outer area and has a black grayish center, that means that this particular calcification is benign. It is not malignant. So I repeat again, breasts can have densities, can have distortions, and can have calcifications. And those calcifications with the center, which does not correspond with its outer area, which center is radiolucent, are benign. But sometimes we also get calcifications which do not have a radiolucent centers, such as this one. Now this left craniocaudal view of the breast has calcification which is punctate. Now punctate means that it has holes. As you can see, these little areas, this calcification is both diffuse and is punctate, having holes. Now this kind of calcification usually occurs in malignant tumors and masses, but this can also happen in benign. So such punctate calcification must always be investigated further via biopsies. A histopathological exam will clarify if the calcification is benign or if it's malignant. Next, we'll learn about the palpable mass. Now, palpable mass are usually found on the physical exam. And then from the physical exam, if the patient is not having a yearly mammogram, then a mammogram is performed and those masses are examined. One such example of this left mediolateral oblique view is this. This is a palpable mass just over the pectoralis major muscle on the posterior of the breast tissue. Now this mass can be both malignant, can be benign, so a biopsy is required. But sometimes what happens is, because of the nature of the mammograms, the breast tissue or the parenchyma is sometimes compressed a little. So what happens is that normal tissue is superimposed upon each other. So it gives an impression of a mass, of a density, but it's not present, it's not palpable. So such masses which are present on a mammogram but are not palpable must always be done concurrently, so that one can be sure that with palpation you can find out that it is not a regular mass, and with the mammogram you can find out that it is just superimposition of the fibronodular tissue. So it is not a true mass, it's just an artifact, a development which is not true. So a good doctor must always be lookout for these. These are the masses or the objects which are usually termed as false negative. So these are the ones which I said are not found on the physical exam but may be observed on the mammogram. Now, every screening mammogram must have a BI-RADS classification. Now, BI-RADS stands for Breast Imaging Reporting and Data System. Now, this classification has 6 categories, and all of these categories must be reported along with the mammogram. And these categories correspond to the severity of the disease, that it's benign, it's malignant, maybe malignant, all of it will be discussed in this classification. So the first classification of BI-RADS is class 0. Now class 0 signifies that the findings are uncertain, they are vague, the doctor is not certain, the radiologist is not certain of the findings. They might be malignant, they might be benign. So these kind of findings are termed as class 0, and for these further studies must always be done. A biopsy is ideal, but a diagnostic mammogram, an MRI, a contrast enhanced MRI can also be done. So further investigations are always warranted when the BI-RADS classification designates a mammogram class 0. Next class is the class 1. In class 1 is the normal study. The patient has normal breast tissue. There are no indications of any density, any mass, any cyst, nothing. So for these patients, what is recommended is routine yearly mammograms. So if something does develop down the line, it will happen later on. But now the patient is having normal tissue. Next one is the class 2. In class 2, the findings are characteristically benign. Now this is very important because in class 2, all of the parameters, all of the characteristics point to being benign. So for this classification, again, we recommend routine yearly mammograms because the findings do not have one single evidence that it is malignant. So a class 2 has the same follow-up as class 1. Then we have the class 3. Now for the class 3, the findings are benign, but they might have some parameters which might arouse the suspicion of being malignant. Now for these kind of classification, for these mammograms, what is recommended is that the yearly mammograms now must be repeated every 6 months. So once a year, from once a year it goes twice a year, because there are a few things on the mammogram which pointed to being malignant, but it's not enough to label it as a malignancy. It's more of benign, but still one must not take risk and perform mammography more frequently. Next is the class 4. Now class 4 has suspicion of being malignant, but it also may be benign. In class 4, the suspicion of being benign and malignant is equal. In class 3, the suspicion of being malignant was lower than being benign. But in class 4, the suspicion of being both benign and malignant are equal. So again, the follow-up advice for such mammogram patient is that biopsy must be performed, because now the suspicion for malignancy has reached about 50%. So again, chances must not be taken. A needle biopsy must be performed and histological exam must be done so as to find out if it's really malignant or benign. Next classification is class 5. And in class 5, the suspicion of being malignant is extremely high. All the markers, all the characteristics, all the findings point toward being malignant. And for these mammograms, again, we recommend that a needle biopsy must be performed. And these biopsies should be image guided so as to perform a good biopsy, that only the tissue that is suspicious, only that tissue is taken from the breast parenchymal tissue. So in class 5, the suspicion of being malignant is more than being benign. The last one is class 6. And in class 6, we know that the patient has a malignancy. There are no characteristics, nothing points towards being benign. All of the characteristics, all the findings point towards malignancy. Patient might even have metastasis. So we know that it is malignant. For these patients, what we do is that we do not perform any kind of imaging, and we move on to the treatment, because imaging has already been done and it is confirmed that it is malignant. So such patients move on to treatment. They directly go on to either radiation or to chemotherapy. Next, we have the mammography requisition form. Now, whenever a doctor requires mammogram and his or her patient is not having yearly mammograms done, and there is suspicion of having some kind of mass, a lump, or it's palpable, or there's some kind of discharge, or there's some kind of dimpling on the breast, for such patient a requisite form is done. A close-up of this form will reveal that such patients must have a thorough examination where the suspicion lies. Either it is the upper quadrants or the lower quadrants, either it's the right breast or the left breast, either suspicion is on the left side or the right side, or in the middle at the side of the areola. Wherever it is, it must be marked, and it can only be marked if the physical examination is thorough. Then the complaints must be marked, such as if it's a mass, or if it's a lump, or it's just thickening, or if there's some kind of discharge. If the discharge is there, is it serous, is it mucoid, or it is purulent? That would indicate that it's infection, or if there's some kind of abnormal dimpling or contour or deformity that is present. Now all of these can only be done again if your physical exam is good. There's the rest of the form, and then we move on to the diagnostic mammography. Now, screening mammography is only done as a tool for early detection of breast cancers. It is not done as a tool for definitive diagnosis. Now, for definitive diagnosis, diagnostic mammogram is done. A diagnostic mammogram usually comprises of, along with the screening one, it may comprise of ultrasound, ultrasonography, or it may comprise of MRI. Or in some patients, if they are diagnosed with cancer, with breast cancer, for the evaluation of the treatment and the staging of that breast cancer, PET examination can also be performed. So for diagnostic purposes, we not only perform the screening mammogram, we also perform the diagnostic one. We can perform both MRI, we can perform CT scan. Both of them can be contrast enhanced, can be without the contrast. Even a PET exam can also be performed in order to diagnose. Now this is an example of a contrast enhanced MRI where the palpable mass is observable, and it has a very typical stellate appearance, that there are spicules and lines that are protruding out from the center of it. Such kind of appearance, a star-like stellate appearance, is usually always indicative of a malignant disease. As you can see, these densities here are not stellate, but this one is. So this contrast enhancing mass has a high suspicion of being malignant. Now, for diagnosis purposes, sometimes we do not have a density or a distortion or calcification. Sometimes we have a simple breast cyst. Now, it can be found out if the mass or the density has clear circumferential borders. Now, if the density has clear borders, they're circumferential and they're empty or they're filled with fluid, it's a dead giveaway that it is a cyst. Now, usually breast cysts are not infectious, but sometimes due to systemic disease or systemic infection, they might turn infectious and they might turn into purulent. So they give rise to an empyema. So if there is infection present, the discharge will also become purulent. So this is an ultrasound image of a simple breast cyst. As you can see here, this is the hypoechoic area. The margins are clear, circumferential, and perfectly round. As I said, for diagnostic mammography, we not only use the X-rays, we use both the MRI, ultrasound, contrasts, and PET. In this instance, for diagnosis purposes, we are using the ultrasound. Next one is the fibroadenoma. Now, whenever we go for diagnosis, usually we prefer ultrasound to a mammogram. Why? Because mammogram gives us the view of the whole breast, but the ultrasound gives us a slice, only a slice or an area where the probe is placed. Only that area it can be examined. So if we can examine it slowly, slice by slice, with the probe using the ultrasound machine, we can be sure of what kind of the mass or density it is. And for the benign ones, the most common mass that can be found in the breast is a fibroadenoma. So on an ultrasound, a fibroadenoma will look like this. It will be a solid mass with good margins and a hyperechoic area around the isoechoic area. So this kind of presentation is a dead giveaway that this mass is a fibroadenoma. Next one. Now this area here is the adipose lobule. Now what happens that sometimes the fatty tissue in the breast is more than the fibronuclear one. So what happens that these fatty tissue clumps together to form an adipose lobule. Now this adipose lobule is of fatty nature. So we can find out that it has a border, a perfect line that goes over it and under it, and it is like a lump, like all of these fatty tissue has lumped together to form it. There is no round circumferential border, there's nothing here. So we can say that this is an adipose lobule, an accumulation and superimposition of all the fatty tissue. And again, such type of mass is benign. Next, we have the fibrous ridge. Now, what is fibrous ridge? Now, as I said that the breast tissue composed of both the fatty tissue and the fibronodular tissue. When the fatty tissue clumps together, it forms the adipose lobule. But when the fibronodular tissue clumps together, it forms a, a certain structure which is thick, firm, and it usually lies on the muscle like a ridge, like a long tube. So this is what is called a fibrous ridge, and it is benign, it is very common, and it is usually found on the patients. Then we have the calcification. Now, as I mentioned earlier, the calcification in the breast is usually of two types. It can be malignant, it can be benign. Benign ones usually have a radiolucent center, but if that center is not present, then there is suspicion of having malignancy. In this mass, one can see there are tiny little calcifications, and these calcifications are multiple, they are around the tissue, and they are benign. Now next we have the biopsy. Now whenever we have mass, a palpable mass, what we do is that we examine it. We examine its tissue, its histological features, and it can only be done via biopsy. And a biopsy is a procedure by which we take the tissue out of a structure. And usually the tissue that we take out of the structure is the one that we want to examine. So in case of breast, the tissue, a part of the tissue or mass or density that we want to examine is taken out of the breast, and it can be done via a needle, and it can be done through guidance, and that guidance is usually provided by an ultrasound, so as one can always find where the mass is. Now, one of the types of the biopsies is called stereostatic biopsy. And these kind of the biopsies are usually done when either the mass is very small or it is calcified. Stereostatic biopsy is when the guidance system has more than one probes. In this example, you can see that this is the needle, this is the needle holder, and this needle holder is going for this mass to collect it for the examination. Now, in order to get to this small mass, one requires very good guidance. So a guidance from only one axis is not ideal for small masses and calcification. So if the guidance is from two axes, biopsy is more accurate, it is more precise, there's more chance of the tissue that we want that is taken into that biopsy. The next biopsy is a simple ultrasound guided biopsy. Now, here is an example of a simple breast cyst, but we want to examine that what this cyst holds. It might be serous fluid, it might be mucus, it might be some pus or purulent fluid. Whatever it is, it can be aspirated via a needle, and for this needle to go right into the cyst and do not puncture the other areas of the breast, we need guidance, and here only guidance from one axis is enough if the doctor is trained well enough. So this is the ultrasound guided biopsy, where the ultrasound guides the needle into the cyst. The contents of the cyst are aspirated and then examined under a microscope. This is the same examination, and it shows that the needle goes inside into the cyst and remains inside the cyst. It does not puncture any other area, it does not puncture the parenchyma. It is only going where we want it to go, and it can only be achieved if we have ultrasound guidance. Now, all of the previous talk was about the patients who are on the average risk for the breast cancer. But there are some patients which we label as high risk. Now, what constitutes a high risk patient and what constitutes a low risk patient? A low risk patient must undergo yearly mammogram screening test, but a patient with a high risk must undergo exams more frequently and at an earlier age. So there are usually three types of patients which are considered high risk. Number one, those patients who have a relative which had breast cancer which was premenopausal. For such patients, their yearly mammogram study is started 10 years before the diagnosis of their relative. So if a patient is having a relative who had breast cancer diagnosed at the age of 40, she must undergo yearly examination at the age of 30. That is 10 years prior to the diagnosis of her patient. The other most common feature of a high risk patient is that if that patient has genetic markers. Now, one of the most common markers which are found in patients are BRCA1 or BRCA1 or BRCA2 markers. These markers are both used as a screening tool to find out the patients who are more at risk for cancer, and they're also used as a tool for certain kind of monoclonal antibodies which target only these tissue. So BRCA1 antigen is used both as a screening tool and as a treatment tool, where the antibody or the monoclonal antibody, in such example we use trastuzumab, which is used and targets the BRCA antigens. The third type of the patient which is considered high risk is the one who has some kind of indication or characteristic on her screening test. So from the screening mammogram, she moves on to the diagnostic one. So these patients who have either characteristics of malignancy on their screening test, or they have some kind of genetic markers, or they have a relative who had breast cancer premenopausally, these patients are considered high risk. And for these patients, the risk is more. And for these patients, the treatment plan and methodology is different. Like if the patient is BRCA1, she is referred to a geneticist, an oncologist directly instead of an radiologist or an interventional radiologist. This is again cyst aspiration ultrasound, but this cyst is of an high risk patient. So the moment this cyst was detected, it was aspirated, both cytology and histology was done, and it was found out if it's malignant or not. This is the needle tip and this is the cyst. As you can see that in this patient, the cyst is also of smaller size. So, what did we learn in today's lecture? We learned about breast imaging, we learned about mammography, we learned both about the screening mammography and its projection and the diagnostic mammography. We learned about the BI-RADS classification system and how it is calculated and what must be done if somebody is or some patient is labeled with one class of the BI-RADS system. We also learned about other modalities of breast imaging. Like we don't only use the x-rays, we use the CT scan, we use the MRI, we use the contrast enhancement, we use ultrasound, and we use even PET scanning, that is the positron emission tomography, for staging and treatment evaluation of cancerous patients. We also learned that what constitutes a high risk patient and what constitutes a low risk patient. A low risk patient must go yearly mammograms after her 30 years of age, but a high risk patient has a different set of characteristics and different age from where her yearly mammograms start. So we learned all of this in today's lecture. Thank you so much for watching sqadia.com.